Dr. Murray, can you hear me?
I can. I'm playing right now, trying to figure out how I can share my screen.
I can see it.
You can see me, or you can see my PowerPoint.
Your PowerPoint.
Okay. That's good. Let me see here. Is that a full screen view? Can you see that?
Yeah, but all I see is click to exit full screen. Seeing your PowerPoint now. There it is again.
Let's see if I download it and then present it that way, but I don't really want to do that.
Yeah.
I could just talk about the email about yesterday. Yeah.
What do you see when I do that?
Click to exit full screen. That's it. That's weird.
Let me try something.
It's just actually. There you go.
Does that work? Does that work better?
Yeah, it looks good.
Okay. All right, just give me 1 second here. All right. You just let me know when you guys are all ready.
We're ready when you are, sir.
All right, perfect.
If you want to give yourself an introduction,
Yeah,
I'm just
absolutely
here to facilitate.
Awesome. Perfect. All right. So if this was in person, I'd just be having you click through all the slides for me. So anyway, thank you all for inviting me today. Good morning. For those that don't know me, my name is Dr. Jason Murray. I'm one of the ER providers at Compass Emergency Physicians that covers St. Elizabeth. Some of you may know me from previous EMS experiences. I work with Independence, Gallatin, Covington, and Hebron. I'm also the Boone County Water Rescue Service medical director. I work at the Boone County Jail. I'm the public health director for Northern Kentucky. I have a lot of hats that I wear, and that's kind of where most of you have ran into me at some point in time. Today, I wanted to talk a little bit about some pediatric emergencies in the EMS, and the title of this talk is No Small Calls. The name fits because when it comes to kids, no matter the size of the patient, every pediatric call is a big deal. These test not just your training, but our composure, teamwork, and sometimes even our hearts. I want to spend the next 45 minutes or so giving you something practical, something that'll help you feel calm and confident the next time that little voice on the radio says, pediatric patient, difficulty breathing. So a little bit about myself, I kind of gave you there before. Couldn't find a better picture. I apologize. But I've had a lot of experience in both EMS as well as emergency medicine. I'm actually specialty trained in pediatrics, where I spent 2 years at the University of Michigan serving as the pediatric fellow in the emergency department. So pediatrics has a special place in my heart. And in fact, preceding going into emergency medicine, I actually wanted to be a pediatric surgeon, but eventually kind of changed due to some familial decisions, decided that emergency medicine was a better fit for us. I'm also a professor at the University of Kentucky College of Medicine, where I train both medical students in kind of their approach to patient care, but also in mainly lifestyle and kind of wellness environments as well. So why this matters? Well, pediatric calls, while they don't happen often, they can be very hard. You can run 20 adult chest pains in a month and feel pretty comfortable, but a single toddler in distress can make the most seasoned medic's hands shake. For the family, this isn't just one of many calls. It's the only call for them. It's their life. They don't remember the hospital. They remember you. They remember the calm face that walked through their front door, that took charge when everything felt like it was falling apart. Your calm, your clarity, and your presence do matter more than any other single medication that you can give in these situations. You are the best medicine. Remember, you are the first link in the chain of survival, and again, that the families will remember you. And at the end of the day, your training plus excellence is what actually saves lives. Apologize there. You are the link. I'm sorry. So today's goal is simple. Build confidence through structure. We're going to take something that feels a little unpredictable, such as pediatric emergencies. What I was hoping to do is to structure it and make this repeatable and something more clear that you could apply in your day-to-day setting when you do go on runs like this. The framework that I developed, not really developed, but rather kind of used in my own career, was taught to me by one of the oldest pediatricians that was working in the emergency room at Michigan. He was about 82 years old, I think, when I first met him. He worked still when I left there at 86 years old. And he told me that with all of these cases, you need to make it mundane. You need to make it as simple as possible. And he applied a framework, which I still use to this day, even in the adult patients, which is someone sick or not sick? And so the simple question I would say that needs to guide you during your initial assessment of any child is to look at them and get a sense of what is really sick and what is not. And so how do you know that? So the pediatric assessment triangle, I'm assuming most of you have seen this at some point in your training. If you haven't, you're going to see a lot of it. It's in most of our protocols. In addition to that, it's a common way that, especially at Children's Hospital, that we tend to assess children when we think of it more often in application, probably in respiratory distress cases. However, can be really applied to any situation in which you're assessing a pediatric patient. So appearance tells you if the brain is perfusing. We're looking for abnormal things such as abnormal tone, decreased interactiveness, inability to console, abnormal look or gaze. So in other words, they're not looking at you, or maybe their gaze is deviated, or an abnormal speech or cry. Work of breathing, we're looking for things like abnormal breath sounds, which can be anything from junky breath sounds to no breath sounds. Abnormal positioning, so tripod positioning, belly breathing, head bobbing. We're looking for retractions, flaring, maybe apnea or even gasping. When it comes to circulation, the skin tells you if the heart is winning or losing. We're looking for whether we're pale or mottled, cyanotic potentially. Cyanotic typically you often see around the lips, sometimes even in the hands, but generalized cyanosis, as you can see here in this infant, is a more common presentation with the kind of the newborns. If you come up to a recent case, maybe where you just had a birth. If any corner of the triangle looks wrong, you treat them as sick until proven otherwise. And so you need to trust your eyes and your gut. They're usually right. So some can't miss red flags that I want to throw out, or harbingers, I call it impending doom, would be things like what we call the silent chest. So when you run into a patient that has asthma or difficulty breathing, and you don't hear breath sounds, despite the fact that they tend to be working hard, that is a red flag. That is something that you need to be working, you have to work quickly, and that this child needs intervention fast. Bradypnea after tachypnea. For those that maybe don't know the term, so slower breathing after a period where a patient looks like they're breathing rapidly, while it can be very common in infants or newborns, is uncommon as children get older. And so when you see a child that tends to stop working as hard without any significant intervention on your part, or just seems to be relaxing, that's not the time to let your guard down. In fact, it may actually be that an impending respiratory crash is to occur. Poor perfusion with normal blood pressure. So even if the blood pressure looks fine, you need to be looking for things like abnormal perfusion. We talked about cyanosis. We talked about things like skin turgor in the past you probably heard about. What we're looking for is whether or not you have good cap refill, whether their color looks well, whether their actual blood pressure matches the clinical picture. Prolonged seizure. So any seizure lasting more than 5 minutes means that we need to act. That's typically at this point, anybody who's had or experienced seizures in the past, you can see that a lot of times families who have had kids that have had seizures, they're usually not calling you until they get to the prolonged seizure, the one that's not breaking with their usual interventions. And so those also need more attention. And then one that always kind of throws me is when a child or any other patient looks at you and asks if they're going to die. For whatever reason, they do perceive that something is wrong, and that usually makes me pause and reassess to see where we're at. When you see those, your internal alarm should really go off for any of these. You should assume sick, call for help early, and act decisively. So let's put sick versus not sick to the test. And so I wanted to display this in a way that would make some sense for what you might encounter when you get out in the field. And so I decided to go ahead and pick kind of the top 5 pediatric emergencies in EMS. And when I say top 5, not necessarily the top 5 scariest, not necessarily even the top 5 things that come to my mind of things that I treat or see often, but rather some of the most common calls that you see in EMS. I think this probably is about 75 or 80% of the calls you'll make on pediatric runs that we're going to go through about 5 cases here and apply our sick versus not sick concept to see kind of what you guys think. Tony, how many people do we actually have in class today? You might be muted. I don't know if you can hear me. That's okay. I'll just continue. So the cases we're going to go over today is respiratory distress or failure, rest seizures and status epilepticus, shock or cardiovascular collapse, traumatic injuries, particularly paying attention to head injuries, and then pediatric arrest. So case number 1 here, respiratory distress or difficulty breathing. So the dispatch is you have a 2-year-old with difficulty breathing, and the mother reports loud noise when inhaling. When you arrive, you find the child sitting upright. They're drooling slightly. They have some inspiratory stridor, and they're in a tripod position. You step in and instantly know that this kid's airway is a problem, and you're working hard but alert. Your parents are panicked, and you ask now to yourself, sick or not sick? I'm going to show you what I thought of when I made this case. Oops. So as you can see here, this child's leaning forward. Their neck is extended. If you see, they're both belly breathing as well as having some supracostal retractions. You can see his mouth opening. He's not head bobbing, but you hear that inspiratory stridor from an upper airway sounds. So what are our priorities in these situations when you come? One is you need to stay calm. Every movement, every noise you make can actually trip that kid into being a full obstruction. Since we don't have the ability to interact, it doesn't seem like as well. In your minds, you guys should be thinking about a couple different things when you saw that picture. One would be things like asthma. Others might be an obstruction, upper airway, something like croup, so narrowing of the supraglottic airway. It could also be something like an ingested object or an inhaled object. These are often can present the same way. So what do? So we keep calm. We want to minimize agitation. We want to apply a normal saline mist or via nebulizer. It can be your friend. It's benign and can buy you some time. Anybody who has had a child with croup or upper airway laryngomalacia, where they have some narrowing congenitally, you'll see that often cool air or humidified air often is a big help. It's one of the main focuses of our treatment when we get them better, is that we want to decrease the swelling in the local upper airway. So when you give them the normal saline mist via nebulizer, that often buys you some time. The presentation we often see with this child in the emergency room is the parents saw this child at home like this, and they scooped them up and they ran to the emergency room. It's usually in the fall or the winter time. By the time they get to the emergency room, this kid is playing and tossing balloons with us and wanting to actually eat a popsicle. And the reason that is because during the transport, they get exposure to cold air while they're transporting to the car, or they get out into the cold car and drive to the emergency room, and that cold air actually helps quite a bit. And so when you apply a normal mist or a saline mist and a nebulizer, that often can do the same thing and provide them some relief. If they worsen, you need to call for medical control. You might want to consider something like nebulized epinephrine. Typically, for our protocols in the region, we use 0.5 milligrams of a 1 milligram ml mixed with 2.5 ml normal saline. If you suspect something like epiglottitis, which is a different emergency, but often presents as also fever, tripod position, but often they'll be drooling. Do not put anything in their mouth. You just want to use blow-by oxygen, upright position, and consider rapid but gentle transport. Again, the big part of these children is that when they're already agitated and there's some airway concerns, they can go sideways and go down pretty quickly if you continue to agitate them. I actually had an experience of this myself. So all of my kids have been kids that have croup. One of them actually had a little bit of laryngomalacia as well, and was continuing to get croup until his probably 8th or 9th birthday. And we had an emergency where one night I walked into the bathroom and I thought he was throwing up, and he was grasping at his neck and clawing at his neck and couldn't get air. I scooped him up and flew about 100 miles an hour up to Mercy Anderson up the street from my home. Pretty much kicked the doors open because they wanted me to register to walk in, and immediately was met, as I was trying to, me already nervous, was met by about 6 people coming at him to try to do something for him because everybody's nervous, and that made him much worse. And in fact, at that point, he actually fainted and passed out on top of that, and I thought we were about to have an arrest situation. Probably one of the scarier moments as not only a parent, but as a provider. And so these situations can go sideways pretty quick, and so it's really, really important that you keep them as calm as possible and try to stay calm yourself. All right, case number 2, seizures. So you're dispatched for a 6-year-old actively seizing, and the family states to dispatch that they're not responding. Your reports as you're coming in says that the child's been seizing, they think, for about 7 minutes or more. They're unaware of any falls or trauma. It appeared to be witnessed by a family member at start. On your assessment, you look in the airway and find it to be clear. Their O2 sat is 92%. But when you arrive, the family is in chaos. Even if they've seen this before, they're shouting, furniture's pushed around, a child's on the floor. You need to take a deep breath, clear your space, go through your routine. As usual, airway, oxygen, suction, check a sugar, right? That's another common one, is that should be always a first trigger, is check a sugar in these children, especially history of seizures and they're prolonged. Even without a history of diabetes, check a sugar. It's a really easy, fixable reason for seizure. When you look, you're thinking sick versus not sick again. So prolonged seizures, what is our approach? What do we need to prioritize? As usual, airway positioning, suction, and oxygen. BVM, potentially if necessary. Consider end-tidal CO2 to monitor with your ventilations. For the medication that we would typically use in this situation is going to be Versed or midazolam. That's our go-to. That is actually broken down, and I know everybody gets a little bit nervous with regards to using your dosing and making sure that you're using the appropriate dosing. One thing to always remember in pediatric patients is no matter how big they are, we never exceed the adult dosing. So that's always kind of your nice upper limit. With regards to the kids, most of you, I think in our region, when you get out and are not only just doing ride time, but actually on the ambulance and doing this yourself, is you're going to have references. You don't want to have to be looking for them all the time or looking through or flipping through books or through your phone. Most of us now have incorporated hand tevi or another style or system that allows you to know or which dosing you can use more rapidly. So for less than 13 kilograms, you can do intranasal or intramuscular 0.2 milligrams per kilograms with a max of 2.4 milligrams. You can also do an IV or an IO dose of 0.1 milligram per kilogram with a max of 5 milligrams. For that intermediate range of a 13 to 40 kilogram child, you can do 5 milligrams intranasally or intramuscularly, or through an IV or IO, you can do IV is 0.1 milligram per kilogram with a max of 5 milligrams. And then for 40 kilograms or more, you're going to use intranasal or intramuscular 10 milligrams, or you could use intravenous or intraosseous 2 to 5 milligrams with a max of 5 milligrams. When you give this medication, you're going to give it confidently. You want to prevent underdosing because that only prolongs the seizure. Once the child stops seizing and is breathing on their own and they become prostictal, they've transitioned now from a sick patient to a not sick patient, no longer critical, but do need support. That's when you can slow down now and monitor. You want to reassess frequently. Recurrent seizures are not uncommon. And then also as you stop the seizures and you're doing your monitoring, you also want to provide appropriate supportive care, positioning, comfort, making sure the child's not cold or overheated. All of those things now become important as well as you transition towards the hospital. Case number 3 is a vomiting lethargic child. So you have a 3-year-old vomiting. They are lethargic is the report from dispatch. Parents report that they are weak and pale as you're en route. When you arrive, you find a child is pale, cool, somewhat mottled. They have a cap refill that takes 5 seconds or more. They're tachycardic into the 170s with a blood pressure at 90s over 50s. The child seems to be alert and eyes open, but somewhat listless and poorly responsive to any interactions or any of your attempts to assess them. You're going to ask yourself, is this kid sick or not sick? Hopefully all of you are saying that he's sick. Here's an example of what this child looked like in my brain when I was thinking this. I don't necessarily agree with that. The child's eyes are open. I wouldn't say that the child is unconscious, but I would say that that is a lethargic child. If you noticed, the provider was attempting to get their attention, rubbing their chest, snapping near their face, none of which was able to get the child to move. I think in our situation, oftentimes when you really know you have a listless or lethargic or sick child is when you know they're sick and you go to do the IV and the child doesn't even pull away when you try to get an IV. You know that you got a sick child at that point. So what are our priorities when we come into a situation like this where the patient is displaying signs of cardiovascular collapse or shock? So one is we need to get access. Oftentimes that's going to mean that we look for IVs. In a situation where you have a very sick child or even an adult that's listless, that's somewhat lethargic, is don't forget that you do have a backup. We've had a number of cases recently, even that I've had to review, where we fought for an IV for the entire time en route. And by the time they're at the emergency department, at that point, they're somewhat obtunded and probably wouldn't have even resisted if you had drilled them. And so don't forget that you have in your back pocket an intraosseous device that allows you to get access and would allow you then to provide some resuscitation en route. I'm not saying you should do this on wake patients. That being said, it is an option for you in a dire situation. Particularly, I have some of my providers are down in, like, for example, down in Gallatin County. If you have a long transport time and route, don't have access to air, and you need to get a line or some sort of access, that needs to be in your arsenal, and you can't be afraid to use it when you need it. So don't waste time hunting for veins if they aren't there. If persistent, so I went out of order there. So, oh, there it was. It is actually there. So you want to provide that initial 20 milligram per kilogram normal saline or LR bolus. You want to reassess and repeat frequently. If you notice that with your boluses that you're still having persistent hypotension, you may want to consider call to medical control. The reason I mention that is often many of us are somewhat apprehensive to utilize some of our tools. Sometimes having another calm presence on the line that can tell you other options that you have. A repeat fluid bolus may be an indication at that point. But then in addition to that is you might even want to consider something like push dose epinephrine if you have access. So 0.1 microgram per kilogram. Push dose epi is it's 0.1 ml per kilogram of a 10 microgram per ml mix. And you can give that actually fairly frequently. I do this quite often in the ER and peri-arrest situations. I often do it for like intubation or respiratory collapse when I have a patient that is kind of quasi-hypotensive or very sensitive to medications because they're undervolumed. And so I will often use that as a tool in my arsenal in order to sustain a little bit of cardiovascular support, both from a blood pressure and heart rate support during either intubations or during procedures. And so you have this tool in your arsenal as well and could use that. And you can do it every 2 to 5 minutes, up to a maximum, I think, for our protocols is a 20 micrograms in total en route. Always when you have medical control online, you can actually do that more if necessary. You want to keep the child warm. Remember that cold shock kills faster. So when we're cold, we don't coagulate as well. If there is any bleeding concerns, you want to cover these children. You want to close doors. You want to also then quickly, you want to be considered early transport to a pediatric capable facility. Transport to a rapid place is important. If you felt like you don't have a lot of time, we've had this happen a couple where children's may not be in the closest closest area for you. You may have a very sick child that you need to stabilize, and if you're not able to achieve that, then that may need to go to the closest hospital available. We've had a number of pediatric arrests even brought to Edgewood. I've even had one down at Covington before. And so at times you may need to actually proceed to a St. Elizabeth facility and rather than going straight to the pediatric center. And so if you feel like you're in trouble and need help and there's an ability to stabilize, you're going to come to the closest hospital. Next case is pediatric trauma. Tis the season as we're getting out of the end of the summer and kind of into the fall. I just actually got back from an ATV and side-by-side trip myself out in Colorado and saw a couple of accidents while we were out there. So this is going to be a teen injured in an ATV crash. The dispatch is that they were helmeted. Friends state that the patient is vomiting and they think that they may have struck their head. On arrival, you find a teen that's somewhat alert, but confused. You find their GCS to be 12. Their pupils appear to be equal and appropriately reactive at that point. The airway is clear. They're able to vocalize for you. They answer some questions, but do so in a confused way. Sometimes the answers aren't quite consistent with what you are asking, and they seem to be somewhat repetitive. Their heart rate is in the 110s. Their blood pressure seems to be stable at about 108/70. They do not complain of anything specifically other than they feel sick. Their SpO2 is 97%. So as you pull up on the scene, the ATV is on its side. The kid is sitting up, dazed. Mom has now arrived to the scene and is hysterical. She's crying. It appears that the helmet did its job. You do see that the child is confused, but you don't see any evidence of head trauma. They had already removed the helmet, but the teen's eyes are somewhat glassy and they're throwing up. So you ask, are we sick or not sick? So major head trauma, when we're thinking about our priorities in EMS, this patient seems to be at least moderately sick, and you should probably have a high suspicion that this child has a head injury and potentially could deteriorate. Sometimes we get lulled into belief that this was on the football field and you ran up to a child that looked like this and seemed confused. You'd think they'd have a concussion. Don't be lulled to sleep in a situation like this with a higher force or mechanism, is that this could be something like a head bleed. And so you want to be prepared for any kind of deterioration. So this is the type of patient that often can look fine and then tank 10 minutes later. So in these situations, we want to maintain an SpO2 of 95% or greater. We want to avoid hypoxia in all head injury patients. You want to keep, so we want to use the bag, we used to bag them fast thinking more air was better. We would often hyperventilate for all these head injuries, but it turns out that also can make it worse. You only will hyperventilate when you find blown pupils or they appear to be comatose or have a deterioration in your presence. Even then, we're only going to try to drop that end-tidal CO2 by about 3 to 5 for a short period of time. Your target blood pressure in these situations are 70 plus 2 times age is one of those that probably can keep in your brain. For a 14-year-old, that's going to be a systolic blood pressure of 98. And you want to attempt to stay above that. You want to control any bleeding. You want to maintain C-spine immobilization. They've already removed the helmet when you get there. At that point, this person is confused with a GCS that's not 15. You have to assume that this child may also have a neck injury given the mechanism and a rollover ATV. So this child you're going to place into a C-collar. You're going to get moving toward the trauma center. Early trauma center activation is important. All of my agencies know I'm a big proponent. I personally love Pulsera. I wish we could integrate it better within our system such that all of our runs were notified by Pulsera. So that way, when patients arrive to the emergency room, you would have the ability to already have kind of made some movement and have a bed ready for more quick assessments and interventions. So do activate early. The trauma centers rely on your early activation. They don't want this 5 minutes out when the patient's deteriorating. When you're en route, give them a call, let them know what you have. What they're going to do is mobilize their entire team based on what your report is, whether that's going to be a higher level, we call it a level A versus a level B trauma at my old institution. And so they're going to assess that. They're going to get that team together and they're going to be on site when you arrive if you give them enough notice. So for a quick recap, we want to do oxygen, perfusion, protection and speed. That's it. If you do those four, you've done right by your patient. What about pediatric arrest? So you get dispatched for a 9-month-old not breathing who is unresponsive. Per EMS, they have initiated no-go CPR, and the CPR is being applied by the mother. When you arrive, mother was actually doing CPR, appeared to be doing it fairly well. The child, however, is apneic and pulseless. You get that pit in your stomach, everyone does, but you take a breath before you walk in. The room is chaotic. You kneel down beside the mother, you put a hand on her and you say, "We're here now. Go ahead and let us take over." Ask if you have a partner with you. Most of us now dispatch obviously multiple vehicles to these situations. This is where it's really important, especially in pediatric arrest, is for scene control, is to have someone that your best communicator on your team really probably needs to get to those parents, provide them a little bit of space and walk them through what you're doing to help them understand that you're there to help. We do not typically, even in the pediatric arrest situations anymore, we do not just scoop and run. Dr. Antevi and others, myself included, have argued for a long time that just like adults, that we really need to do very good CPR on scene, and we need to kind of get our opportunity to save this life right then and there. When we scoop and run, we often lose that and have poorer outcomes. Bystander CPR was already ongoing at this time. It looked like it was good CPR. Now we move on to the next steps in our assessment and what our priorities would be here. So the big one is deep breath. Here's kind of our order. We need to stay calm. High quality CPR. So we really want high performance CPR. Most agencies now in our region are training on their high performance CPR measures. Good rotation of members. Each person often is assigned before or en route to the scene as to what their role is going to be, who is going to be meds, who's going to be airway, who is going to be compressions. Most of us now, you will also notice, have mechanical CPR devices available for our adult populations. Most of the time, especially in a kid at this size, that's not going to probably be an option for you. You want to avoid hyperventilation, so we don't want to overbag these children. You want to use a BVM. You want good seal. You may consider, particularly if they don't respond within your first 2 rounds of CPR, to secure an airway. Remember that in pediatric arrests, the most common cause is different than adults. Often in pediatric arrests, those are due to a respiratory cause. So airway is very, very important. It has a little bit higher priority than in adult situations, although you're going to take a very similar approach. So you are going to want to get a supraglottic airway or possibly an endotracheal tube if required. Cuffed versus cuffed really doesn't matter as much anymore. I think most of us at this point have cuff tubes. Some do carry both. At this point, use what you're comfortable with and what you can get at this point because you just need to secure the airway. Early defibrillation is always important in any arrest situation. In these pediatric arrests, they do tend to be a little bit more likely to be shockable rhythms. So you're going to encounter more VF or pulseless VT. In those situations, again, we have a dose adjustment for our intervention. And so for your initial shock is at 2 joules per kilogram. Your second shock typically then goes to 4 joules per kilogram, and then any further shocks you can go from 4 to 10 joules per kilogram, but we don't want to exceed our usual adult dose. From a standpoint of medications in these situations, you're going to use your epinephrine, 0.01 milligram per kilogram IV or IO. You're going to do that every 3 to 5 minutes. That is a 0.1 ml per kilogram of your 0.1 milligram per ml concentration. If no IV or IO established, you can use the endotracheal tube if you've secured that airway with a endotracheal tube, and it's a 0.1 milligram per kilogram with a max of 1 milligram dose via the endotracheal tube. If rhythm persists, you have refractory or persistent VF or VT. One of the big things I've been telling a lot of people, this is usually if you are on scene working these situations, particularly in children at this point, but also in adults, you should start be thinking now about how we're going to mobilize when you have refractory cases to where you're getting to second line drugs or you've had multiple shocks already. The drugs of choice that you could use in the situation, you can use amiodarone at 5 milligram per kilogram, again, via IV or IO if that's established. You can do that twice to a max dose of 300 milligrams. You can also use lidocaine at 1 milligram per kilogram IV or IO push. The biggest thing to remember is that most pediatric arrests, again, start with respiratory or failure or shock. Prevention is our real best resuscitation way to resuscitate, and you want to catch it before it spirals. And so when you see these kids, like I showed in the first video, the first case, and that you have a child in respiratory distress, is typically early intervention there is going to prevent you from having to see many of these in the field. You're going to get called out on pediatric arrests in poor cases with co-sleeping or SIDS cases, sometimes also congenital abnormalities. The case that sticks with me the most is Covington had a few-day-old infant that one of my more seasoned providers went and found them to be listless. By the time that they got out to the ambulance, they went quickly en route. They were assessing and went to get an IV and such and realized the child had stopped breathing and was pulseless. They were planning children's. They diverted to Edgewood. When they rolled into Edgewood, this baby who had CPR pretty much was in the medic's arms, was getting one-hand CPR. Brought into the room. I actually was not part of the case initially. They worked this child probably for 20 or 30 minutes. We're concerned because we weren't getting recovery with such a young child that there was actually what looked like a VF and VT that was refractory. We changed out the airway. We actually were concerned about the lines. We actually used the tube for medications. We eventually got some better access. We actually found blood sugar is way high because we had actually, they had given, I think, that before they even checked the sugar. And this child was in persistent VF and VT. We worked him for about an hour, and actually the original report when we called the NICU was that they said that we should probably stop. We ended up continuing. This is one of those one-off cases where if I followed the guidelines, I kind of wouldn't even know, but this child actually ended up living. This child is normal now. They had a abnormal fatty chain acid metabolism problem that essentially made them severely hypoglycemic and had an arrest because of that. So these situations, when you see some of these arrests, aren't always respiratory. And so you've got to remember that, but the predominance of these is that they are typically respiratory in nature. So some key takeaways. So I always want you to think of is when you see a sick child is use your pediatric triangle. That is going to help you identify that big important question of sick versus not sick. Remember that in the field, one thing that I try to also is that no, you aren't trained, you weren't a doctor, you didn't go to school for 10 years, you didn't get to the point of where you're often necessarily looking for the definitive diagnosis, but you do need to be able to identify patterns and recognize direction. You need to have the right tools to stay calm and be able to apply them. Things like the pediatric triangle, it's a 30-second cheat code. It allows you some clarity. It lets you kind of answer that question on whether these children are sick or not sick. And then you want to really focus on the ABCs. You want to master these top 5. These are scenarios that I do think that you're going to see the predominance of any sick peds that you're going to see or pediatric runs that you're going to see. These 5 cases are probably going to take up the majority of those. Respiratory distress, seizures that are persistent, cardiovascular collapse or shock, traumatic injuries, particular head injuries, and pediatric arrest. I think that those are going to be the 5 that if you prepare for, number 1, you'll be more calm going in, know the tools that you have. And again, focus on the ABCs, not just the diagnoses. Don't get lost in fancy terms but just remember airway, breathing, circulation. That's really your North Star. Kids don't need heroes. They really need experts. And that's who you guys are when you bring the calm, the skill, the compassion to some of the worst moments of any family's life. You guys are built for this. You came into this for the reason to help and give back. It is never an easy situation to walk in to a very sick child or a child that's arresting. It's really the heart of my message is that while the medicine matters, your mindsets and your demeanor is really what's going to make a big difference as well. So I want to thank you for your attention. I would invite any questions or comments or concerns. I know I wasn't able to hear you, Tony, if you were talking before, but I wanted to lay this out as more an overview of a nice approach or way that you could walk into any situation, make an assessment, hear a little bit about the top 5 things that I often see with regards to sick kids. And just remember that pediatric calls are tough. They're always going to be. They bring with them emotion, fear, and adrenaline. I hope that after today, you'll walk around knowing you're capable and prepared. You're not alone. You're going to rely on your team. Every skill you practice, every protocol you memorize, every calm breath that you take before you walk into these scenes, they all really do matter. And so no small calls isn't just my title. It's a mindset. It's a promise to show up present, purposeful, and prepared. So no matter the size of your patient or the chaos of a scene, that you the next time can go in and hear the words child, you can take a deep breath and slow it down and know that you've got this. So I'd like to invite any comments, questions, or concerns, address anything that maybe has triggered any thoughts in your mind that we could discuss as a group. Be glad to answer any questions.
Dr. Murray, thank you.
Yes, I can hear you.
Okay. We usually don't get a lot of chat afterwards immediately. A lot of times we get some follow-up questions later. As you know, we record these and let the other shifts get a chance to view them.
Perfect.
So that's when some of the questions come up.
Well, I put my phone number and my email here. I would invite any of you, number one, put me in your phone. I am always free to chat when it comes to anything with regards to EMS, pre-hospital care, things that you see, things you want to change, or if you have any interest in public health or extensions of EMS into other areas of medicine as part of our team, please reach out. I often have projects. I often have different things that I'm doing that I'd love to get more involvements. So if there's a way that I can help you make your job a little bit easier, if there's any way that I can serve any of you, please reach out. I would love that. And that is my cell phone. That's a direct line to me.
I know a couple times I've called you with questions in the health department area of we get a patient who says that they're TB positive, and most of the times we find out that they're a inactive case or something like that.
Correct.
The amount of concern we have for TB in the area is, I think, way overkill.
I could speak a little bit to that. So at any one time, I would say I have probably 4 to 6 active cases. We usually have on the order, and anybody that doesn't know that, I could speak to that a little bit, is 2 weeks of treatment with improving symptoms pretty much eliminates 99% of infectivity. Or the likelihood of transmission. Most of these patients, it used to be that we wanted culture conversion. So we'd actually want to see that they had nothing coming up in their actual sputum, and that they weren't growing anything out. That takes 6 weeks to culture out. And so oftentimes these people were put on like 6 to 8 weeks of isolation. Historically, all the recent literature and data would suggest that once we've had them in an appropriate clinical situation where we've initiated appropriate therapy, confirmed that they don't have resistance to our first line drugs, after 2 weeks, they don't have the bacterial volume to spread or be infectious to others. We tend to still tell them to wear a mask in public and those things until their cultures completely result. But typically, we do take them out of isolation from kind of their family members and those kind of things as well, so that they don't need to be isolated at home anymore. The social separation and isolation that is a cause, obviously that's important that we don't infect the community, but at the same time is the individual nature, the fact that these people are going to be in treatment for 9 months when they have active TB, with only about a 90% cure rate in those situations. Some of them will have advanced disease, some of them will have dissemination to other organ systems, but the majority of the times when you run into our TB patients, if they tell you they have TB, that probably means they're in treatment. The ones that are more concerning for all of you would be when you come across an immigrant population or recently came, they're sick, they appear sick, they're coughing with thick sputum. Look, we all got burned out on COVID, right? And wearing the masks and all that kind of stuff as well. You guys all have N95s. You guys all have the ability to protect yourself. We're getting in the flu season and those things as well. And while I get it, like it's used to be a shield, a sign of I came to work sick when you had flu and your COVID and stuff and you came back. The truth is when you run into these patients, especially immigrant patients with risk factors, I would recommend an N95 or higher level mask on your initial encounter.
Trash this. Take these and put it. Take these. We just these around.
Tony, any other questions?
Let's see. I'm not seeing anything at this time, but again, thank you. And so we're doing basically a 3-part pediatric series. So
Nice.
we've got you today. November is going to be one of the flight nurse. She's a pediatric trauma nurse. So she's going to concentrate just on trauma.
Nice.
And then December, we're going to do some cardiac respiratory type things.
Go over the new some of the PALS updates and things.
Yep.
Okay.
And that's going to be Chris Barber from Air Evac.
Nice.
The PALS classes have kind of deteriorated in the area. It's hard to put it together. So I'm trying to make up for it because PALS isn't a required card anymore.
Right.
So the classes aren't I don't know. They're not there. So trying to make up for it this way.
I'm glad to fill any gaps if you have a lead at Children's. Obviously, they probably should be kind of our lead. That tends to be who we all sometimes, we tend to defer to children's for most of our protocol committee stuff. So we tend to now, my caution I always give is that they also, even though they have a EMS, transport team and everything else there, is that they aren't usually the ones seeing these children first in the field. And sometimes application of in-hospital medicine to pre-hospital care, it's easy to do in their mobile MICU transport unit. It's not necessarily as easy to do for us. And so if there's any way that I could bridge that from what we see in Northern Kentucky or Greater Cincinnati pre-hospital setting and an initial encounter, be glad to provide some perspective and then come in and help if I can.
I appreciate that. They're actually going to be participating in our conference this Thursday with some simulations and teaching. So yeah, we've got a good relationship with children's, and just trying to get that part of very few runs, but very sick patients.
Right. Yeah, I think I did probably 2 or 3 years in a row. I think I've done the pediatric cardiac arrest lecture at Hebron at the refresher. So always glad I keep that updated every year, every new release. And so I'm not doing that this year. I handed that one off to somebody else this year. But glad in any way I can help with regards to that if you should need it.
I appreciate it.
Absolutely.
If anybody
Well, thank
got
you
any
for the
questions, yep. Thank you again for your time. I really appreciate it. And we'll catch everybody next month. I believe it's going to be November 4th. I'm confirming the date with the trauma nurse right now. All right. Thank you all.
Thank you. Appreciate it, everybody. Take care.